Hi, everyone. Welcome to today's webinar. We'll give everyone a few minutes to log on. People are transitioning from busy days. Once the numbers kind of taper down, we're going to introduce today's webinar, but we're happy to have you. Thrilled you're here, and hope you're ready for a conversation. Numbers are ticking up. As you're kind of coming into the room, we'd love for you to type into the chat where you're coming from, your connection to PSP, CBD, or MSA. It's just nice sometimes to see where folks are tuning in from and connections. So feel free to send that in the chat to everyone, not the hosts and panelists. Otherwise, not everyone will get to see your message. So we'd love to hear where you're tuning in from for this CurePSP and Mission MSA webinar. Feel free to keep chatting that. In about 1 minute, we'll get started. I see those numbers ticking up still just a little bit. Great. All right. So far, we have a mix of diagnoses and relationships to the diagnoses. It's good to have you all today. Okay. All right. Numbers are starting to taper, so I'm going to get just lightly started, Ella and I. Again, welcome to today's webinar. It is titled Reflections, a Conversation About Choice at End of Life. We are thrilled that you've chosen to join us for such an intimate and vulnerable conversation. And also welcome to the first ever collaborative webinar between CurePSP and Mission MSA. We do a lot of work together, but today we're really excited to collaborate to bring our communities together because there's so much overlap between the communities we serve. And to introduce myself, my name is Courtney Malberg. I'm the Associate Director of Education here at CurePSP. CurePSP is an organization that aims to raise awareness, build community, improve care, and find a cure for Progressive Supranuclear Palsy, PSP, Corticobasal Degeneration, CBD, and Multiple System Atrophy, MSA. We operate off of 3 main pillars, which is care, through our support groups, care centers of care network, quality of life respite program, etc. Consciousness, which is education and advocacy for these diagnoses, and cure, through funding and supporting research, supporting brain donation, and making important connections with pharmaceutical and biotechnology companies. There's so much more we do, but hopefully that's a nice overview. And today I'm joined by Ella Cox, and I'll pass it over to her to introduce herself and Mission MSA.
Yeah, thank you so much, Courtney. I'm happy to be here and really excited to be partnering with your PSP to have this conversation. We know that it's a really important one for our community. So for those of you who might be new to Mission MSA, we're a nonprofit dedicated specifically to improving quality of life and building hope for people affected by multiple system atrophy, or MSA. And we do that through a really large variety of channels, mainly through education, advocacy, research funding, and then support programs designed for patients, families, and care partners to help navigate life with MSA. And so we're really excited to kind of have this conversation with you guys and our community. And I'll pass it back over to Courtney.
Sounds good. Thanks, Ella. So this is a topic that CurePSP and Mission MSA have been working on incorporating into our educational programming. We've had a lot of conversations and questions over the years through our general information emails, our phone lines, connections we've made in person. And so we're choosing to talk about end of life via medical aid in dying today, which I will refer to as MAID. I want to iterate that this webinar is not endorsing any particular choice or treatment, but instead providing education and answering common questions asked by our community. The goals of today's webinar are 1, to provide accurate and objective information about medical aid in dying or MAID. 2, acknowledge and address the unique considerations for PSP, CBD, and MSA. And then lastly, hear from individuals who have lived experience to foster a dialogue about the importance of choice at the end of life and what that means. Again, we deeply understand that this is a sensitive and vulnerable topic. Please know that you will receive the slides and a link to the recording of this webinar later this week. Should you feel the need to step away, you'll have access to this information later. Take in this information as it feels right for you. Lastly, at CurePSP and Mission MSA, we greatly respect and understand that individual perspectives vary greatly. They're often shaped by personal, ethical, religious, and cultural beliefs. We respect these different viewpoints and understand that some community members may wish to not interact with this topic, and we please ask that you respect each other's opinions on these matters, whether in this chat or in the real world as you interact with people with PSP, CBD, and MSA. Okay, with all that being said, we have about an hour and a half today. The first 30-ish minutes will be a presentation from some experts, and then we'll welcome up our panelists to the screen, and the 4 of them will have a conversation and To that point, if you have any questions for the panelists, we encourage you to ask them. You can do that through the chat function or through the Q&A function on Zoom, whichever you prefer, and we'll get to those questions. If you have questions that aren't about today's topic, please feel free to reach out to both Mission MSA or CurePSP. You can reach out to CurePSP by info@curepsp.org. Ella, do you have an info email you'd like to share? I'm sorry.
Yeah, we do. You can reach out to us at info@missionmsa.org.
Okay, perfect. I'll share those both in the chat, but you can reach out to either of us and we'd be happy to chat. So with that, I'm going to welcome our speakers. I will welcome Dr. Lonny Shavelson and Thalia DeWolf, registered nurse, to the virtual stage. All right, you're both.
Okay. Hi, all. Thanks for coming.
I'm going to leave it to you guys, and I'll talk to you about half an hour.
I'm going to say hi too, just so I show up.
Hello. There you are.
Yeah, we'll introduce ourselves. So I just looked, there's 78 people here, so that's fantastic. It's an amazing group. It's our honor to talk with you. Let me just put up a brief introductory slide so that I can tell you a little bit more of who I am. And it goes here. I hope I get the right one. There it is. Let's go that way. Okay. So Thalia and I are leaders at the Academy of Aid and Dying Medicine. And just to be sure that there's a sense of who we are, contrary to what it may seem by the title of what we have on that slide, Academy of Aid and Dying Medicine, we are not advocates for aid and dying. We've never lobbied for a law. We've never talked about why it should happen. We've actually never encouraged any individual patients, although Thalia and I have had more than 400 patients who have considered or completed medical aid and dying. That's not because we asked them to. What we're about is to say that medical aid and dying is now legal in 14 states. It covers about 30% of the population. And we believe very, very strongly that as a new field of medicine, if people are going to participate in aid and dying, and I'll define that term in a second, if people are going to participate in aid and dying, we just want them to have the best practices, the most evidence-based care, the kindest and most compassionate care that they can receive. Not because we're saying, oh, you should do aid and dying, that's a good way to die, or even a more dignified way to die, which we don't believe, but because of the fact that for those who choose aid and dying after getting all the information about what it is, we want them to get the best care possible.
And I think just to chime in a little bit, Lonny and I ran a private practice for a number of years. And so we saw in the field, and I'm a former palliative care nurse, so we saw in the field how these patients were being cared for, and we saw some lapses in their care. And so we closed our private practice and held a conference and opened the academy, and it's been amazing, going full bore ever since. We gathered data and crunch it, which I know Lonny will talk about. But what I think is crucial here is that we noticed that clinicians were really hungry for information about how to take care of these patients, and that's where we came in.
So what is aid and dying? You will notice that I don't use the term MAID. I kind of watch people get, it's actually called medical aid and dying. And that's where the MAID acronym came from. I find that that's rather confusing. If I go to a patient's room and I say something like, we're going to do MAID today and talk about MAID, I see them looking around thinking that their house is dirty and why am I asking them to get a MAID? So I avoid that acronym. We can say aid and dying. It's about 2% faster than saying MAID. Okay, so aid and dying is the process where patients who have inevitable deaths, and it's defined by law as they're going to die within 6 months. I'll talk a little bit more about what that means and how we ascertain that. So these are not people who are choosing to die. These are people who are choosing the way they will die, usually in the final few weeks of their life. And so aid and dying itself is also called a hastened death. The reason we don't use death with dignity as a term is because we don't feel like aid and dying has a monopoly on dignified deaths. People have dignified deaths by the way they interpret their own deaths. You can have a dignified death in the ICU, hooked up to all the machinery you could think of, fighting for that last 2 hours of life. And if you consider that to be dignified, then that's a dignified death. And so we don't use the term death with dignity. We'll talk about aid in dying. We'll talk about medical aid in dying. We'll talk about hastened deaths. We have various terms for it, but death with dignity is not one of them. We would like it to be understood that everybody who dies the way they want to die has had a dignified death. Okay, so aid in dying then is the process by which you qualify to have the criteria, and we'll talk about that, the criteria to participate in medical aid in dying. And then as you approach death, we as clinicians will work with you on continued conversations about what we call the how you may die conversation. The how you may die conversation is different for every individual and every illness. It says, this is what your death is likely to be. Now let's talk about how you would like it to be. Maybe just hospice care, maybe a ventilator, maybe not a ventilator, maybe a peg tube, maybe not a peg tube. So we go through discussions about options. The difference of what we do if we're aid in dying clinicians as well is one of the options we have is if you are severely suffering or just so fatigued that you can't tolerate for the next 1 to 2 weeks, when death is inevitable, we will then offer a liquid material that is a combination of toxic materials that will initially put you deeply into an unconscious state and then stop your heart and lungs once you're unconscious. We can talk as you want to about how that pharmacology works, but I'll skip that for now. So fundamentally, what I'm saying,
I just want to nail what we're talking about here, and we hope the main thing that you will take away, and I know Lonny will say this, is that medical aid in dying it's not just about a prescription. It's really about the care, and no patient has really decided ultimately to complete or to ingest the medication until the moment that they do so. And it's really all about the care that leads through that process. That's what we learned. And we didn't know going into this what it was going to be. This was a lesson that's been learned over and over again as the Academy has developed.
So our language has developed to accommodate that. We never talk about patients requesting medical aid in dying. We always say they are considering medical aid in dying because aid in dying is not a moment of time, a momentary request, or the receiving of a prescription. It's a conversation as death approaches of all of the choices that you have. So let's get specific now, if I can. Somehow that slide didn't want to advance because I didn't put it on play. Let's try that. Still not advancing. Slideshow, pick one. We'll go from start. There you go. All right, let me get my pictures out of the way. So I want to talk a little bit about, and I've picked multiple system atrophy, although it's fairly similar to for progressive supranuclear palsy, and for I just blanked on my last name. Talking about yeah, certainly for ALS, and we'll talk more about that. And for where did I go?
MSA.
MSA. I missed the last of your three in your group. It'll come back to me in a second. Sorry, I'm getting old. Okay. The causes of death. It's really important to understand if somebody has MSA or PSP or somebody just speak up in the room.
ALS or
no.
Corticobasal
MSA.
degeneration.
It's
Can
the
you hear me?
cerebral
Corticobasal.
Corticobasal atrophy. Thank you.
Thank
you. Sorry about that. Don't mean to insult this corticobasal atrophy people. Okay, neurodegenerative diseases of the brain in general, and we're going to kick in ALS in a little bit as well. Here's what I wanted to talk about, and I'll use MSA as the example. The cause of death is in that left column with percentages, and the percentages then go on towards that right column. The major cause of death at the top is listed as a cardiopulmonary arrest. I'm going to consider that to be artificial just for the sake of talking, because everybody always dies of cardiopulmonary arrest. Their heart stops. That's the final aspect of death, right? Something always leads up to the cardiopulmonary arrest, Although the people with neurodegenerative brain diseases, because the brain doesn't communicate well with the heart in some cases, do actually have true cardiopulmonary arrests as a cause, as a reflection of the central nervous system diseases they have. But it can come from a lot of places. You'll notice in the second column here that you can see that 24%. When you add up that 24%, those are all of the things that relate to the lungs: aspiration pneumonia, infectious pneumonia, acute aspiration, and I left out the wasting syndrome. So we add those up, that's 24%. That's right on top of the cardiac arrest. So mostly in our experience, the patients who have neurodegenerative diseases like these die of something related to the lungs. Didn't mean to do that. Sorry, come back. And so you'll get pneumonias. And the reason, obviously, is that as your brain loses function of controlling the airway, people will not be able to swallow safely. They will cough, they will sputter, and they will aspirate some of the what they're eating. They'll eventually aspirate some of the bacteria-laden secretions in the mouth. And so pneumonias are one of the leading causes, as is respiratory failure, as your chest doesn't expand to get enough air in. You will eventually experience, and I'm blunt in my language, suffocation. So we have heart arrest. Urinary tract infections is the second on the list there. This is
Very high.
very high on the list, and I'll talk about a little bit about the
Why that
mechanisms.
happens.
And then the pneumonias, and then down below we have smaller levels of, I thought it was very interesting. They included cancer because I presume people with neurodegenerative diseases get cancers as well, but that's a little bit weird that they put that there. Okay, so let's look at how this happens. 33% of patients with the neurologic diseases we're talking about have poor communication between the brain and the heart. So as the brainstem, the lowest part of the brain that controls respiration and others, will have the heart will sometimes run slowly, sometimes run fast. Come on now. Okay. And so you're going to have a certain number of patients who will just suddenly die from a sudden cardiac arrest. And that's from, again, the degeneration of brainstem centers. The lung function, and this is what I think is what's to understand the most, is eventually it is the brain that drives your respiration. And it comes from usually low in the brainstem at the back of your head. And as time goes by, those respiratory centers will be turned off, just like everything else happens in PSP and MSA. So you get degeneration of brainstem respiratory centers. And then along with that, you get aspirations. Sometimes the vocal cords become paralyzed. And so it's very, very, very hard to move air in and out through the vocal cords. Let's just jump down to related aspirations, acute and causing pneumonia, about 18% of all deaths. And that's because we've all had that where we swallow wrong, and that's a gag reflex. You start coughing and sputtering. But if the neurologic control of that gag reflex has been turned off by the degenerative neurologic disease, that gag reflex goes away, secretions get into the lungs, and then you get aspiration pneumonia or acute aspirations where you get so much in there it destroys the lung. Back up to urinary tract infections. This is not only, as is commonly thought, because Foley catheters are put into bladders and they cause infections. The Foley catheters are put into diseased bladders that aren't functioning. So before you get the Foley, you have neurologic bladder dysfunction with retention of urine, and that urine just sitting in the bladder, even if you don't put a Foley in it, tends to get infected. Then when you do put a Foley catheter in it to drain the bladder, or you do straight cathing or Foley to bag or however you're doing it, infections are a very high risk. And so some people will die of infections about 24% of the time. Down at the bottom is the slow turning off of the entire body. And so that when the brain is no longer really controlling things, you lose swallowing, you achieve weakness, you have gastrointestinal dysfunction. That's the wasting syndrome of about 14%. The reason that I give you all of this information is so that you can imagine what these various deaths look like. This is what I priorly called the how we die, how you will die conversation, or more appropriately, how you may die conversation. We have serious conversations with patients with all the neurodegenerative and actually all diseases about what your death is likely to be. And then we admit we may be wrong. We're making educated
Yeah.
guesses based on experience. And so it's important to know that if you don't have a healthcare worker who is telling you about what your death is looking like, ask them. They know. If they say something like, we hear this from hospice sometimes, and it drives us crazy. Well, everybody's death is different. We can't predict that. We don't have a crystal ball.
We don't have a crystal ball. That's
Yeah.
the famous thing.
Tell
And
them
yet,
that's wrong. Tell
well,
them,
and yet I think that is our area of expertise. It is a difficult conversation. So I think most of the social workers on this call, everybody is going to be, trained and skilled. It is still a hard conversation. Emotions can come up. It's good to take your time. And yet having this discussion with patients is often a huge relief. And what we commonly say is that here's the information that we know, and here's the mystery of dying. It's huge. And yet, knowing some of this information and sharing it can be very just soothing to patients. They now understand, even if it's still a little bit scary and it's almost always a little bit sad, having that information can relieve that jagged edge of anxiety.
I think it's important to know that this information is frightening, but it is also palliating, meaning it's relieving. And the reason is this: we will never say to a patient, "Look at this, you have about an 18% chance of suffocating." That's a very, very frightening word. I don't hesitate to use it because I think patients understand, want to understand and deserve to understand. By the way, they can also always stop the conversation and say, "I don't want to talk about that anymore," and then I stop. But when I do say you may suffocate, the first thing I'm going to say is that, and we will make sure that you are comfortable throughout that process. So we're not abandoning you to be, sort of having a 3-day suffocation. If you enter the realm of that level of shortness of breath, we will make sure that you are rapidly unconscious while that's happening. So that we always talk about, this is how you may die, and this is how we will make sure your death is comfortable. And it doesn't always include medical aid in dying. By far, it's just called general palliative care.
And sometimes even with suffocation, or what I would say is serious, severe shortness of breath, we do have tools that will help manage that. It's not out of the question. And I think people don't know that. When they start to experience that shortness of breath and they start to feel it, it's very scary. Is it going to get worse? Is it going to keep going? I've had a lot of patients say, I'm terrified of using morphine because that's the hospice drug. But when I've sat with them and given them the low dose that's required to kind of quell their air hunger, patients are always surprised and tearful and delighted, and I'm right there with them very commonly. It's not unheard of, and I think that's crucial. We need to explain this is the typical, what we call trajectory or pattern that we might see, and here are the tools that we might be able to use to keep you comfortable. So
here's why I think it's important that we're here talking to you. Some data about the different diseases. Thalia and I, in our practice over 6 years, as Thalia mentioned, her first patient was a patient with PSP, Progressive Supranuclear Palsy. We have since, in just our practice, we had 7 patients with MSA, 19 with PSP, innumerable patients with ALS. I did have a couple with Corticobasal Degeneration, but I have to say that I don't have enough that I was able to get into the records and count them. So, but they're there. And the reason that I point that out is, you guys, these are rare diseases, and we saw a lot of them. So I have really good data on ALS, and I just want to give you a sense of why I'm doing that. ALS deaths are only about 2 of every 10,000 patients in the country on an annual basis. So 0.02%, 2 of every 10,000. But ALS aid in dying deaths run about 10 to 15% of all aid in dying deaths That's about 12 of every 100. So when you think of this on a population basis, if ALS is very rare in the general population, it's very common in aid and dying. And the reason for that is that ALS deaths, like deaths from PSP, MSA, and corticobasal, I'm going to finally get a corticobasal atrophy. The rate of asking for medical aid and dying and completing it is astronomically high for neurodegenerative diseases. So ALS, for the example, where deaths look kind of like the deaths that you have in your population, when you calculated that, 625 times what we would expect from the population incidence of the disease, 625 times higher in their requests for ALS. If I play out that data for MSA and PSP, what we get is 5 out of every 100,000 people have the disease. But, whoops, I did it again. We've had 26 patients within our experience alone. That means it should have taken 5,200,000 deaths. We are seeing MSA and PSP patients asking for medical aid and dying about 160 times more than the incidence of the disease in the population. Again, why? Because they are frightening deaths, and people want to be reassured that they have a way out without going through that frightful last few days. Okay, that's something else. So that's what we wanted to talk about here. I'm going to get rid of that for a second and
I think the other component that I just want to mention, yes, these deaths can be frightening. I think these diseases are kind of unrelenting in a particular way, and they take patient autonomy away so rapidly that I think a lot of patients, I mean, this is just conjecture, but I think a lot of patients want the sense that they have some control at the end of their life. And so I think the considering medical aid and dying aspect of these neurodegenerative diseases kind of, ultimately that could be one of the components that plays out here.
Okay, so given that, and given that you all asked some fantastic questions, I'd like to just take a quick sort of run with Thalia through these questions. And by the way, somebody from over at the bosses here, Courtney, I presume, when we hit our 30 minutes, just stop us, because we're going to move just into some questions that we thought you asked. The questions that were submitted to us for doing this presentation were fantastic. And I would just, by the way, what you're seeing at the top here is the Academy website, and that is aadm.org. I'll leave that there for a little bit while we talk. So question 1, which states allow medical aid in dying? I can hit that right here quickly. So that is this one. There's a map. Let's see if I can remember my geography. States that have medical aid in dying: California, that's Oregon, Washington, Montana, that's Colorado and New Mexico. We just got Illinois this year, just signed on, as did New York. We've had Maine and Vermont for some time. There's a piece of New York down there. There's New Jersey. Washington, D.C. is kind of thrown in here as a small one. There's Hawaii. And I think I've now covered
Delaware.
all the states. Delaware.
About
came on. There's
32%
Delaware.
of the
I'm sorry.
population.
No, this is that's Illinois.
Oh, yes.
So Delaware is
Tiny,
down
tiny
here. There
up
it is.
there.
This tiny thing
Yeah.
here. There's Delaware. Okay. So 14 states, 30% of the U.S. population is covered by medical aid and dying. So that's the easy answer, the quick one. Let's jump down to Thalia. Can somebody be in hospice and pursue medical aid and dying?
Yes, they better be. We want them to be. Why? Because much as we believe in autonomy, we are not in charge of the molecules, is something I commonly say. So in other words, the really important aspect of having hospice on board while a patient considers medical aid and dying, because hospice is, going to be caring for them, their family, their symptoms, really emphasizing, hopefully in a perfect world, providing them with really good palliation of symptoms and supportive care and all the other aspects, including, spiritual support. It just does so many important things that medical aid and dying does ultimately not do. So, and we highly recommend it.
How can I ask my doctor for medical aid in dying? That's a tough question. That depends on who your doctors are. For those of you who are at different centers of excellence for neurodegenerative disease care, as they have near us at the University of California, San Francisco, you can just bring it up because they have a very active aid in dying program. For those of you who are just working with your primary care doctor still, if you bring it up, they may not know anything about it. It's still a new and rare practice. One thing I'm showing you here, our page, when you if you are considering aid in dying, you don't have to be concluding. Remember, it's a process you go through about making a decision or not. But if you want to find aid in dying care, you go to our Academy's website where it says Find Aid in Dying Care. It's under the Patients and Families tab. And you scroll down and there's a form, if I have this right. And that form something you fill out in detail so we know a lot about you. And then we will help you find aid in dying care. It
It's
may be a
free
bit
of
frustrating.
charge.
No.
And we have referrals all across the country, 3 main sources, and that's large health systems where they participate, hospices where they participate, and independent providers. It's a form that we get and we forward to providers. And one of the things that I didn't say about hospice, there's a question up here about how does a doctor certify that I have less than 6 months? Well, one way is to look at the hospice admission requirements. And for neurodegenerative diseases, there are specific criteria. And they're often a constellation of things. But if you qualify for hospice, typically, it means that you are headed towards being eligible for medical aid in dying is a possibility. Not always, not 100%. There's a margin of error in there. But the hospice eligibility criteria is usually impaired breathing, loss of function, needing more help with ADLs, weight loss, those sorts of things is what we commonly see with neurodegenerative diseases. So it's another component of hospice care. So
I've taken a moment to put up we're talking through a lot of this very quickly. Everything that we are saying is written in the Academy's Medical Aid in Dying, a guide for patients and their supporters. Again, on our website, you can just go to the Patient and Families tab, and you will find this book. I'm particularly recommending this book because I wrote it. And so I'll just
I was
say
a
that.
reader.
You can get it. By the way, you can read it free as a PDF. We want it to be accessible to everybody. You can buy it from Amazon, or you can just read it free as a PDF, so you can do it any way you want. The goal is to mystify and facilitate the processes of medical aid in dying.
It's
Okay.
a good read, 44 pages. I also summarized some of it on our essential patient and information page. So if some of this material doesn't quite stick, you can go to that page. We have a lot of questions answered there.
Yeah. So again,
yeah.
This is not to be too pluggy here, but the Academy of Aid, it's aadm.org, and there's a Patients and Families tab over there. Courtney, are we over our presentation time, or should we keep going with questions?
Yeah, I mean, we can address questions, but I just wanted to, let's get into some logistical aspects of MAID. I know people have asked about the process and which states allow it, and the states that allow traveling and things like that. And so I'm curious if we could touch on that a little bit.
Yeah. Well, the states that allow it, I went through. The states that allow travel, I'm going to tell you the states, and then I'm going to tell you why I don't think it's a good idea. The states that allow travel are Vermont and Oregon. They say that they're open border states. They will take people who can come from any state. But here's just something to think about.
Well, and though I do want to say establishing residency in other states is not impossible.
Yeah. So for instance, you could come to California where we are and establish residency within a few days and find people to take care of you. The problem is that by the time you're ready to consider aid in dying and know whether that's your path, you're very sick. And that certainly applies to patients with the neurodegenerative diseases. Travel is not easy. You have to travel to these states. So let's use Vermont and Oregon. You have to be there during the entire waiting period, which in Vermont is 15 days. So you have to stay there for 15 days. If you do leave the state after that, you have to come back to the state where you're going to take the medications to die. You have to die in that state. Usually you bring your support team and the staff with you and loved ones. I think that if we look at the question of you want a dignified or you want a comfortable death, you're not going to get it by traveling from wherever you are to Vermont or Oregon, stay there for 15 days at an Airbnb with all the staff it takes to take care of somebody with a neurodegenerative disease. Meet new people, meet new doctors, get into a new hospice, etc. So while, yes, it is possible to do, and it was a hard-fought political battle to open up the first few states, as clinicians, Thalia and I have a real hard time with thinking that that is a wise thing to do.
It is not always ideal.
I do want to be sensitive to those who do choose that, of course. That can be right for some folks. Yes.
Yes, for some folks, it is exactly the thing to do. We have taken care of patients with the neurodegenerative diseases who came to California and established residency just by having a rent check for the first month. So it's pretty easy in various states. It's not that nobody should do it. It's that it should be looked at with a great deal of caution.
Yeah.
That's all.
I think what we've learned over time is that patients have this idea that they're just going to zip into a state and consider complete medical aid and dying. And what we've learned over time is that they come quite sick. And I think that people had not anticipated that, much like they didn't want to talk about what the actual process of dying was like. So I think the other question I see that I think is really important for us to address before we get to over our time is cognitive function as well as ability to swallow. So Lonny?
I'll take cognitive function. You take ability to swallow.
Deal.
Okay. Cognitive function. Let me put back up a slide, if I may, because I made one for this. It's fairly straightforward. You all seeing that? I hope capacity. Cognitive function means the following. In order to participate in medical aid and dying, nobody can make the decision for you. That's a safety in the law. And so in order to decide and ask for and get medical aid and dying medications and then take them, you have to maintain throughout the ability to think to a certain level. So I've put up the legal definition. This is California Probate Code 4609. It's similar to what is in every state in our union. And it says that in order to have decision-making capacity, you have to understand the nature and consequences of the decision. You have to make and communicate that decision. And I'll talk about communicate in a second. And in healthcare specifically, you have to understand the significance of your illness, the significance of the intervention that's about to happen, the benefits, the risks, and the alternatives. Now, that may seem like, oh my God, most of our people with MSA, PSP have difficulty with communication. Some have cognitive disabilities. They'll never make it. Not true. The easiest way for me to say this is I can sit with a patient and say, I know you're having a hard time or cannot speak. Blink or nod, whatever your method has been to communicate, that counts. You don't have to speak verbally. I'm going to ask you, is your disease prostate cancer? No. Is it multiple, is it MSA? Yes. Okay. You know what your disease is. Do you know that you can have hospice care and die a comfortable death with hospice care? Yes. Do you know that if you take these medications, you will die? Yes. That person has capacity. So, fundamentally, if the person has no ability to understand what's going on anymore, then they're excluded from medical aid and dying. But if they have basic cognitive abilities and some ability to communicate, I can make them qualify under cognitive abilities. Thalia, you want to take swallowing, and I'm going to put up.
So swallowing, we know for neurological diseases, it's not uncommon to lose the ability to swallow or to struggle. And I have to tell you, the medications come as 2 ounces, but they taste god-awful, and they are not easy to swallow. So having your hospice nurse assess your ability to swallow going forward is crucial. Here's an interesting thing. Can you use a PEG tube? Absolutely you can. In fact, oddly, for neurological diseases, I'm a palliative care nurse. We ask people to really consider carefully if they want a PEG tube. It's not necessarily going to, lengthen their life. We know that it doesn't prevent aspiration pneumonia when we thought that it did. So I will talk all about that with patients. But for patients considering medical aid in dying, it actually can give them a little bit more time because they're not depending on their swallow to ingest medical aid in dying. So actually, a PEG tube is easier, I think, and probably, amongst like it's a really important thing to consider. It's actually really helpful to have a PEG tube for these patients. It may give them an extra couple of weeks to live because now they're not waiting until they can't swallow and can't take in fluids. So it's a weird spin on the avoiding PEG tube questions. The other thing I want you to know, and you're all sitting down, this is good because actually there is one more route and it's rectal administration. And when I say the word rectal administration, a lot of people sort of like, oh, gross. Like, what's that like? I have to tell you, it's very dignified. I had one gentleman sitting up in his tuxedo you can see a picture of the catheter. The catheter only goes about 1 or 2 inches into the rectum, and the medications are about half a standard enema. It's very comfortable. You don't have to swallow or taste these nasty medications. So that is an alternative to PEG tubes for patients with dysphagia, difficulty with swallowing. So yes, it is possible to use other routes. I think what's important here is that especially rectal non-oral administration requires a careful assessment of whatever part of the GI tract we're going to be touching, either where the PEG tube lands or where the feeding tube lands or the rectal catheter. We want to be sure that that area of the gut is going to absorb the medication. It's going to be able to do so. So it's really not just, just put a catheter in there. It requires some attentive medical care. So I don't want to go too much into those details because I want to talk a little bit about what the procedure looks like, whether it's oral, rectal, or via PEG tube. So
Okay.
does the procedure look like? I think we're going on to the next question.
Are we on time, Courtney, or should we go?
Yeah, we should do a few more questions, but then we should welcome Alyssa.
Okay.
But yeah, this is a good question to answer is what Thailia was going to get
to understand what the procedure looks like. So it's kind of demystified because it's not just I just take a pill and I go to sleep and I die. It's not like that. It is still the process of dying. We really strongly recommend that. I think in the media, it looks easy. But in reality, having an attentive person who knows what dying looks like and who can be there for you and for your loved ones, who can really hold the space. I mean, I know that's a corny phrase, but really be there to help you understand what is going on is super, super helpful. We don't recommend that families prepare these medications alone without someone either coaching them through it or preparing. It is legal for a nurse or a doula or a volunteer to prepare the medications and to present them to the patient, either to swallow or to depress the plunger to a PEG tube, a feeding tube, or a rectal tube. So that's a component part that I think people really didn't know until we got into this, how important it is to have someone there who knows the process and knows what it looks like. Typically, once a patient has ingested the medication, meaning they've swallowed or depressed the plunger, it's into their body, the next part of it is that patients very quickly go to sleep. The medications are 3 really strong sedatives and 2 medications that slow and stop the heart. But the most important piece of the puzzle is that patients go to sleep. They very quickly have a relief of any of their shortness of breath or their pain. Their last moments of being awake is typically pretty comfortable. It can be sudden and surprising, but patients very quickly enter a coma. And once a patient is comatose, they do not experience any of the symptoms that the family may be seeing. Changes in color, changes in breathing. Sometimes a patient's body will tighten and relax. That's very common. And the procedure is still the process of dying. So having someone at the bedside saying what you're seeing in the changes of color, or the person is not taking a very deep breath, you may hear a sudden, very profound deep breath after a person hasn't taken a breath for a while. That is what we call an agonal breath, and it's stimulated very, very deep in the brainstem. When the brainstem gets a sense like where the oxygen go, it can stimulate a very deep breath, but it doesn't mean the patient is feeling shortness of breath. So once a patient is comatose, they may have some agonal breathing. They may have changes in colors, very common. And then most patients die within 2 hours. What's the percentage, Lonnie? I think it's like,
We have about 85% within 2 hours. The 2 to 10 hour range brings it up about 98%.
so it's not instant. It can take some time. It can take anywhere between a few minutes to the day. But as long as the patient stays really comfortably asleep and the family and loved ones are really well supported by knowledgeable clinicians, then it takes as long as it takes.
Mm.
And typically at the very end, patients' breathings become kind of shallow, slightly irregular. Their heart rate kind of slows and becomes irregular, and then they're breathing and their heart stop and they die. So that's the
I
procedure.
have on the screen is a video enactment that we produced at the Academy with actors showing what an aid in dying day looks like. This is a patient who's dying of lung cancer, so it's very different than someone with a neurodegenerative disease. But the basic flow of the day and what happens after someone's unconscious is detailed in the movie. It's an 8-minute video that you can all watch to get a sense of what that is. I would
Good.
suggest at this moment, speaking of breathing, we have delivered some heavy stuff here.
Yeah.
So
heavy.
let's all
Take a breath.
breathe and then move on.
That's a good idea. A deep cleansing breath. I like that.
Mhm.
That's great information on the aid in dying process. I am now going to, with this transition, welcome Casey and Alyssa to the stage. And I just want to recognize, as Dr. Shavelson just said, this was some really heavy stuff, and appreciate you all sticking around and hearing about it. I hope it answered some questions and gave you some maybe a better understanding and some more confidence as you go through the diagnosis and the journey. If you have any questions, feel free to reach out to us and we can talk about that further. Just in the interest of time, want to move on to our panelists. And so this is now our open Q&A panel. People can feel free. We're going to address some questions that were already sent in the chat, but if things come up as we continue talking, please feel free to send those. And first and foremost, I want to introduce our 2 new guests. We have Alyssa Fox. She is a speech-language pathologist whose mother had MSA. She passed in March of this year and pursued MAID but opted not to utilize it. Alyssa brings a deeply personal perspective to this panel through her experience as both a clinician and a caregiver for 3 beloved family members during the final chapters of their lives. And we're also joined by Casey Sheska, who lives in the mountains of New York and runs a beautiful inn. Her mother had PSP and chose to peacefully end her life using medical aid in dying, surrounded by family and friends. Casey's insight on this topic is both profoundly emotional and helpfully practical. And so we're going to start off by letting Casey and Alyssa give a little bit more context and to themselves and their stories and their mothers. So first, I'm going to just pass over to Casey, if you want to just kind of intro your story.
Sure. Thank you so
Thank you.
much for having me, guys. And thank you to everyone who's here today. I love that you guys are doing this. This is something that I would have really loved to have had available for me and my family when we were going through this. So I'm very happy to be on the other side and hopefully offering some element of help and clarity. So my mother was diagnosed with PSP, not this past fall, but the fall before, after the usual zigzag of, medical complications. And she was very determined once she learned what the classic causes of death were, she was very concerned about her lack of independence, physically, mentally, all of this, and has always been the type of woman who wanted to take matters into her own hands. And so in some ways, no one close to her was surprised when she said, I'm going to look into this medical aid in dying business. And we lived in New York, and at the time it was not available here. And so we talked to folks in Vermont, and it looked like it was going to be even 6 months to be able to meet with somebody. We talked through all of, like Lonny had mentioned, all of the travel that would be happening back and forth. And then we called on a whim the End of Life Choices folks in Oregon. And they were like, you could come out next week and we have this team ready and these are the people. And we were, at this point, obviously we'd already been talking about it for months. And my mom made the choice that we would all go out there together. And we did. I'm saying, I lived across the street. She was living with my dad, who was the primary caretaker. And then I shared responsibility. I have 2 children and a husband. They stayed behind, but I went with my dad and my mom. We were in Oregon for about a whole month because even though it was a 14-day waiting period, there's a lot of logistics. There was, we had to get a new hospice team. We had to, straight up find the proper place that we could take the medicine because you can't do it in a public place. And we were staying at a hotel and it counts as a public place and things. We kind of joked, but not really, that I was essentially the producer of the event. And I'm a small business owner. I'm a very organized person. This was like a way that I felt I could serve in this time. And then it also allowed for my mom and my dad to have more kind of closeness and be in the emotional aspects of what the end of life was for right then. And yeah, she wound up, again, her physicians and everyone is very clear, as the way that you guys have been, that this is just, you're getting a prescription. You don't have to use it. You can change your mind even after the medicine has been made. And my mom had absolutely made her mind up. And she wound up, this was last March. So surrounded by other loved ones in a beautiful house. It kind of went exactly as described. She drank the completely bitter tasting medicine that she followed up with her favorite raspberry sorbet. She fell asleep and it took about 3 hours and her heart just slowly slowed down. And we felt in very good hands because the prescribing physician was there the whole time to kind of walk us through what we could expect, what she could expect, and all that. And it wound up being a really beautiful thing where we actually sat around. She literally died to the sound of us laughing.
Beautiful story. Thank you for sharing that, Casey, and we'll dive more into
Yeah.
it. Alyssa, if you don't mind, just giving an introduction.
Yeah, thank you so much again for having me and for allowing me to share my mom's story. Casey, like you, my mom was just determined, beautiful, organized. She suffered with MSA-C, which again, she passed away March 20th, but we chased the diagnosis for probably a decade. She was officially diagnosed in April 2025. And we really, over the last couple of years, saw the symptoms amping up. I think due to my father's passing, my younger brother who passed away, I think all these things contributed to the symptoms really accelerating. And as that was happening, she definitely kept asking me, begging me for help. What else can we do? She was such an independent person, and watching every bit of her humanity being taken away. Last summer, she said, we need to do something else. So my husband and I researched. I spoke to the palliative care team at our primary care, Penn Medicine, movement disorder clinic. They got me in touch with a medical aid in dying physician. I spoke to that physician, and then I remember the day I talked to my mother. I had a very difficult conversation with her, thinking, how am I going to present this to her? She's asking for help, but I know she also doesn't want to die, but she's very in tune to her body. She sees what's happening. And I remember walking with her outside. She was in her power chair, and I told her what I found, and she found this immense sense of relief. Here, I thought this was going to be the most heartbreaking news that I could share, because I felt like I was always one step ahead and could figure things out, and we could pivot and figure out how to have her access life. And now I'm presenting this option to her. But she felt relief. She wanted to have a conversation with the physician. We did. We had a conversation with the one practice. And then subsequently, I found out there was another practice even closer to our home, part of a large hospital system. that also happened to take insurance. So that was very helpful because that's a big piece to talk about as well. So that was very helpful. And we started that process in the fall with the first request, and we were finished up by November. And we knew we would have that prescription available at the specialty pharmacy, but my mom wanted to persevere as long as she can still access some level of life. And obviously that changed and evolved and was extremely difficult. But we did, and she avoided all hospitalizations until February. She was admitted in February with pneumonia. She went back to her assisted living for 1 week, and a week later was admitted again. And we looked at each other and we knew this is just going to continue to be a cycle. I knew, I'm a speech pathologist. Her swallowing was very impaired. I knew where we were just going to continue with this loop. So at the hospital, she actually asked me to call the doula and let's set this up. So I called the doula and I started, but I kept saying, let's see how this goes. She knew I would support her, but obviously I was having a hard time still with it, as I'm sure many family members can relate. So we decided in the end to come home, have her come home to my home where she had lived previously. This was her final wish, and to come home with hospice, all while knowing we still had medical aid and dying available to us. In the end, we did not use medical aid and dying, but I have to say, when she first got home, she really rallied and looked better than she had in a very long time. It was unbelievable to see, and we did create more moments. She had moments with my grown children. She had moments with myself, my husband, visitors, family, friends that are family. So I appreciate and find those blessings in all of that. And then that last week when things were really getting difficult, I said to her, Mom, we can still do this. And I figured at that point, I knew she wouldn't be able to swallow anymore, that we would need to go the rectal route, but that she could still use the syringe to do that. And she said, let's see how the week goes. And I think she knew at that point she was not going to make it the week. And so she died in my arms with hospice care. And we did not use medical aid in dying. But she felt like such a sense of control, just knowing that that was available to her. And at any point we could pivot and explore that. We knew we had it available, that it was ready for us. I also chose not to bring it into my home, which I know was told to me I could do, to have it in a lockbox within my home. I felt better with it at the pharmacy for my own self. I know that's, a personal decision, but that's what we decided. And every step of the way, I said, I'm here, we can do this. And we knew it was available. And that's making a very long story short because
Yes, we had to condense a lot, I'm sure. And that's actually a fantastic segue, Alyssa. Thank you for sharing. The next question I wanted to ask, which is to all of our panel, from your professional and or personal experience, how did choice fit into this conversation? Alyssa really highlighted that, and the choice of her mother's choices along the way, Alyssa's choice in choosing to keep the medication at the pharmacy. How did that support, hope and confidence and independence in your journeys and your parents' and family's journeys?
I'll just echo
my
that.
mom. Oh, I'm sorry, Casey.
I was going to say, I'll echo that my mom felt the same when you were saying, like, such a sense of relief in knowing that there was, because it's a decade of all this uncertainty and this slow decline of losing like independence. And then again, she also reached a certain kind of cliff and was very nervous about, what was going ahead. And the relief was so important. And just the relief in knowing she had the choice again.
Absolutely, the choice. And my mom knew ultimately I was going to support whatever she wanted. We were a team and we were doing this together every step of the way. But she was also being a mom and she was worried about how I was going to handle it. If she had chosen medical aid in dying, she knew that I was going to do everything I could to accept that and go forward. I'm the one who found it for her, but she definitely had concerns for me. As we've talked about, she was clear thinking, she was cognitively intact. So she was being a mom up until the end.
So Alyssa, can you clarify? I may have missed it. What state were you in?
New Jersey.
Ah, okay. That
Here
was-
in New Jersey. And the hospital where she ended up being with her pneumonia also happened to be the hospital system where the doctor was in charge of medical aid and dying, that we chose that, that particular practice. So I felt like it was all meant to be the journey. And again, we went through palliative care. And then I had reasons to hold off on hospice again because of sort of the things that my mom would not have been able to gain access to. She was still, I was getting her a communication device. She was still getting PT and OT. And as we know, all these things would have been cut off. So we really tried to access as much as we could until we realized now with the hospitalizations, we weren't, she was declining.
Dr. Shavelson or Thailia, do you guys have anything you want to add to that? It's okay if not.
Just you did everything. You did all the right moves. That was incredible. That navigation is so hard. And wow, for both of you, it's just great to hear because I've been on the other side where I see patients that, through the process just kind of fell out the bottom. So I just think, there's so many little details. I don't want to take up too much time, but both of you guys, Casey and Alyssa, wow.
Thank you. There's so much involved with it. And I don't know about you, Casey, but for us, my mom and I were a team. We honestly, my husband did tons of research. We did not share this with many people. We kept it, we wanted it to be her decision. We knew there were a lot of thoughts and feelings about it. And we just wanted it to be her decision, and just get her the information and be able to provide her the support we could. In the end, we did tell my adult children what the possibilities were, but we wanted it to be hers. It was the last thing that she had left to control when every other bit of control was being taken from her.
I think what you both really described fantastically was what I summarized at the beginning, which is that aid in dying is not a request, it's a process. And patients are considering aid in dying. When somebody says to me, I want to do aid in dying, and they're 3 or 4 months from death, or even 5, 6 months from death, my first question is, well, let's talk about how you might consider aid in dying as one of your choices along the way, because everybody's death will evolve differently. And it's very, very hard to predict exactly what will happen to you at the end. But let's keep this as one of your options. And that's exactly what you both described, and did some really, really hard work. Again, this is a new field of medicine. You lucked out. That's why, Alyssa, I wanted to find out where you work, because I know the people in New Jersey. I also, Casey, know the people in Oregon, and I could guess who your doctor was.
They're great.
And so there is a process of you got to self-advocate.
Absolutely.
There is a shortage of doctors. We are doing our best at the academy. We train physicians, we train nurses, we train social workers, we train hospices, we train hospitals. It's a big job, but it's a new field of medicine. And you may run into the fact that nobody knows what you're talking about or how to find you help. In those cases, people already listed Compassionate Choices, Death with Dignity, 2 organizations. We're the leading clinical organization. The Academy
And
of
we have a
Medicine.
referral system.
Yeah, and we have a patient referral system. So sometimes there are shortcuts that we can help you with, but you did it. You guys did the advocacy role perfectly. You did the considering word perfectly, and then it plays out the way it plays out, and you just kind of follow how it goes.
The other thing that both of you kind of highlighted is just how much advocacy this takes. The access question is huge. It is not easy to access medical aid in dying. It's already kind of a taboo topic. And, so in terms of costs and all of that, it can be really complicated. So just highlighting some of that, finding a place, figuring out where you're going to get coverage, all of those questions, I feel like that's why, having stories is really crucial.
And the costs really are, like I said, the first practice we talked to, we were looking at a substantial amount of money, which of course we would have done anything for my mother. So but I could see that being a barrier. Then where we ended up, that wasn't an issue at all. I mean,
Right.
the medication is what the medication is.
Right.
That seems standard as far as for what my experience was. But I did also find that the hospice agency we used, it was very important to disclose we were considering medical aid and dying
Yes.
because they also had thoughts and feelings, some of the, about it. And they made sure to staff us. Our hospice agency was amazing, but they made sure to staff us accordingly with a nurse that was very familiar and that would not be taken back with that process should my mom choose. So I think that's important.
I think that so the costs, typically the meds are not covered and they're around $700. The care itself can be covered by insurance. Sometimes healthcare systems or hospices, if you can find them, if they're participating, fully participating, meaning they allow their providers to act as prescribers, that kind of is covered. Sometimes you can't find that, and it's only independent providers. Sometimes you have a choice of all three. Independent providers are on the scale of over $5,000 is typical in almost every state that I know of. The care is very attentive. It's very quick. It's wonderful, but not everybody. And usually the independent providers will slide their scale, but there are goods and bads to all of these systems. And I think the systems that I know of in New Jersey are often quite integrated, and in Oregon, both of you navigated them fairly seamlessly, though, I have to say.
Thank you. And I have to say, the attending doctor and the consulting doctor that we dealt with just gave my mother her dignity. Like, really just,
Right on.
again, like you're saying, it was a process, but made her feel heard and just like a person again when everything else was being taken.
That is a wonderful statement because that, in the end, the goal is not to just provide medications, it's to provide care. And that's kind of like the slogan at the Academy is that it's not about a prescription, it's about caring for patients. And so it sounds like that worked for you.
Great. This is fostering a fantastic conversation. It's fantastic. So I wanted to back up and ask about this, and this can come from any of you. Talking to friends and family. Alyssa, you mentioned that you kept it pretty quiet, and I'm curious how that conversation went with, telling loved ones, even maybe your own personal reactions, and our professionals, if you have any experience from witnessing this happen many times.
I can hop in and say that similarly, we didn't wind up telling many people, especially because we were so nervous that it wouldn't work out. There seemed to be so many hurdles, just bureaucratically, that the idea of everybody flying out there and then having told people that she was going to possibly pursue this, and then everybody trying to say goodbye and then maybe coming back, it was just not what my mother wanted. Which I understood. Simultaneously, she did actually decide to say goodbye in person to a few friends. And then once we were out there, they realized and as the pieces started to come together, we found someone in the chat asked where we wound up spending her day of death. It was at a friend of a friend's house. Well, as we got closer to her chosen death day, because she had decided that that's what made her feel good. At the end of the 14-day period, she wanted to have that day set for herself. As we got closer, she actually decided to start to tell a few other people. And she wound up having this really beautiful, we kind of talked about it as a living eulogy. People wrote back, they called, and said all the things that you usually only hear at a funeral, and she got to hear them all herself, which kind of made the last weeks of her life, while she was far away from community, actually quite beautiful. And as someone, just even for me and my dad to hear it was just really lovely. But yeah, had we told other people, I think I answered.
Yep, there's no right or wrong. They're doing
sometimes you start answering and you find yourself somewhere else and you're like, where did we begin?
And that's the point.
Yeah, I think it was hard holding back from my, again, adult children who are in their early 20s. I wasn't sure ultimately what my mom was going to choose, and I just didn't want it to be in the back of their minds ongoing until it needed to be. So, again, I think there's a lot of education that has to happen. I think, people are just confused and unaware. But I kept telling my mother, again, we were on this journey for a long time together. I hope that I can do something with all of this and all of this information. And now I'm happy to be able to talk about it. I wish she was by my side, but her picture is right here with me. She is with me. And I know that she'd want me to share. But at the time, it was just very deeply personal. And she just didn't want anyone or anything to get in the way of what decision she needed to make, because she was so clear thinking. She was so in tune to what was happening to her body. She knew every step of the way when changes were happening.
Yeah, they know more than anyone else on the outside knows. In the same way that in my dad, my husband, like me on the outside, even though we were the closest kind of caregivers, were initially, it felt more sudden to us than to her. And she could just, in retrospect, she could feel the cliff that she was on. And even in those last few days, she was kind of floating away. Like we really felt like we threaded the needle with her. But yeah, again, it's their choice. It's their choice the whole time.
Yeah. And we just tried to make the moments matter, the ones that we had. And, she said, let's see how the week goes. And the week, I think, went the way she wanted it to go. And she was surrounded by love. And I was holding her. My children were there. My husband was there. Her oldest son had gotten to see her on the phone. And it happened the way it should. But again, it was always a consideration.
I do want to highlight before we continue, the theme I'm seeing between those two stories is that there can be a peaceful, loving death, no matter kind of how it happens. And so combined with what Dr. Shavelson and Thalia presented earlier with those stories, I think that paints a really, well-rounded photo of how its choice isn't just choosing and dying, it's choosing the plan that you make for your death, the people you bring in your circle, the research you do. And so I just wanted to highlight that theme that keeps emerging for me.
And I think what the Dr. Shavelson said before, that they're not choosing. My mom did not want to die.
Right.
But she saw she had this horrible degenerative condition that was taking her. And as much as I tried and took her everywhere, to all the large institutions, every doctor possible, every specialist stood by her side, we couldn't stop it. It was, so we could only make the best of the time we had and make the best choices together. But it wasn't her choice. She fought until the end, but she knew when there was no more fight to be had.
I'm looking at the time, and I do have a few kind of trending logistical questions, which I think might be more for Dr. Shavelson and Thalia, but feel free to chime in. One question we received in our registration that I want to kind of make sure we touch on is how cultural differences play a role in decision-making. This is a decision that could vary by, any, faith-based, ethical, maybe like family-focused, individualist cultures. And I'm curious if there's any data or just opinions that you have on kind of how you've seen the differences of those decisions.
I'll just grab at that. I think there are certain family situations, especially in religious families, be they Christian, Hindu, Buddhist, almost all, where there's some conflict in the family. And what we've experienced mostly is that we and the social workers of hospice and the chaplains involved basically try to just sit back and tell the families that we're available for them. Here's an example. I had a patient who had severe colon cancer, very, very uncomfortable, down in the Central Valley of California. His family were all devout Catholics, very, very well known in the community, 12 children and their grandchildren. and very, very tight with their priest. And dad just said, I cannot do this anymore. He was lying in bed. He was unable to move. He was a rancher and typically would be very, very active. And he heard about medical aid in dying and just said, this is what I want to do. And 11 children and his priest surrounded him and said no. And within 2 days, it was, dad does what he wants to do anyways. And what we've learned about families and conflicts and cultural differences is fundamentally, this is not their first rodeo. They have been through conflict before. They know each individual in the family. They know who's going to be okay, who's not, who's going to insist on doing what. And if we basically just say, we're here for advice, ask us questions. One of the most common questions is, why is this not suicide or is it suicide? And we'll answer questions like that. But fundamentally, families work out issues. And when somebody is dying, it's very profound watching how well they come together. And so what I got to witness was on the day of Aiden dying for this person in the Central Valley. I walked in the door as the priest was walking out after doing the final prayer. And the priest walked out, shook my hand. I shook the priest's hand. I walked in. The family greeted me, except for one son who wouldn't face me while I was there. And I was fine with that. And we sang the rosary in Spanish around the bed as the patient was dying. And I sang along with them. And everybody got together and we all hugged when the patient died. And as I left, I got 11 hugs from 11 children and one who again turned his face away from me. And again, I thought, that's okay. So these things are generally worked out. Everybody asks a lot about family conflict.
They do.
We actually have found it to be surprisingly uncommon.
Well, and it is the same for all hospice patients. You will continue to have the conflicts that you've had in the past. You know, death is like a little pressure cooker. So I'm not going to say that it's always perfect, but it's dying, and dying is rocky. I think the other thing I just want to touch on is you'll see in the statistics that it's like white educated people who generally access medical aid in dying. Well, actually, you don't. The question is like, how many people complete medical aid in dying? And it's like, oh, white and educated. What I want to say is this form of healthcare faces the same barriers that every form of healthcare in the United States faces. And so you're primarily going to see white educated people have better access. So that's reflected in the numbers that we see, but it's not clear how many patients would have wanted medical aid in dying but didn't have access to it. We'll never know what those numbers are because they don't show up in the statistics.
I will say that some of the statistics are also debatable. In our practice, we had a very significant number of Asian patients. And we were told before we started our practice that we wouldn't see any. We had a significant number of African-American patients, although not proportionate to their population representation. And part of that, in our experience, was also seeing African-American families tend to take care of their own. And those patients get really good quality end-of-life care along with hospice. And so there are cultural differences, which I think are fine. More religious communities tend to do less aid in dying. Cultures that tend to take care of their patients, their family members very, very well, use less aid in dying. That doesn't mean that there's, it does mean there's lack of access. I have to say there are many people who have tried to access aid in dying and who have failed because they don't have the access to the internet as well. They don't have access to high-power doctors. They don't have access to travel funds. So it is true that there is an access problem, and it is culturally, ethnically, and economically based, education-based as well. That's a problem we need to deal with over time. But as Thalia just said, the sad part is we work in the American healthcare system. And the same of what I just told you applies to kidney failure and to good cardiac care and to cardiac transplants. All people who have less economic means have less access to good health care. And if you consider aid in dying to be one aspect of good health care, we're right in there with everybody else. It's an access problem.
That's a great answer. Thank you for sharing that. We have a question, and this is a question that I think is very common and one that maybe not spoken out loud very often. but oftentimes MAID or aid in dying might be thought of as euthanasia or suicide. And do you have any insights on kind of how those differ and some wisdom into that?
So I'll take that. I think Lonny kind of already said it. Euthanasia is a doctor deciding that it's time for you to die. That is not how medical aid in dying happens. You have to have, you have to be uncoerced. It's a decision you make for yourself. And just the simple act of ingestion is a way of saying this is your decision to proceed or not proceed. Whereas typically euthanasia, it's not legal anywhere in the world. I don't think euthanasia is actually legal, where it's just that the doctor administers the medication or a healthcare person does. I think the key thing that differentiates medical aid in dying from suicide is that these patients are dying. They've been typically evaluated by 2 doctors in the United States. One that is the attending prescriber has decided and proven, documentation-wise, has said that this patient has got a less than 6-month prognosis, meaning they're dying. The consulting physician confirms or denies that. If there's disagreement, they may have to come to some agreement and say the patient isn't quite terminal yet, and when we see these signs or symptoms, they will be. But medical aid in dying, patients are dying. They're not choosing between living and dying. They're choosing between dying or dying or dying. Which way do they want to die? That's what differentiates it from suicide. It's not assisted suicide. It's assisted dying. I think what I stole this from somebody, I don't know who, but typically patients who are considering medical aid in dying don't want to shorten their life, but they may want to shorten their death.
Yeah. I'll say too, when we explained this to my children who were 5 and 7 at the time, that was exactly the way we described it. Like, she is dying. She is shortening her death. And we even described how it was going to happen. It made complete sense to them. And I thought, well, if that's how a 5 and 7-year-old can get it, then that's how the rest of the world can get it too.
Right.
To clarify, I want to be clear also. Suicide is a tragedy. And I think every time this question comes up, I want to be clear about that. Suicide is somebody who has a choice of living, and either by making a decision or by being forced by their mental circumstances, they end their life when they have a good life ahead of them or the potential for a good life ahead of them. None of the patients I have ever helped with medical aid in dying had the choice of living. And so, but I really always acknowledge also that suicide, if we were talking about suicide, we're right there with everybody else. Suicide is a tragic event.
Very insightful, all of you. Thank you for your answers. I think that's probably really helpful. I think this is a question that many people probably have percolating in their heads, and I'm glad someone asked it. So thank you. All right, we have just a few minutes left. There's one more logistical question I have, and it's one that we've gotten a lot, is can I still donate my brain if I utilize MAID to end my life?
Yes. Okay, I'll just give you the short answer. Yes. You can't if your brain is still alive. So no donating living brains. But once you die by medical aid in dying, your brain is quite eligible for that without any question.
I appreciate the consideration of brain donation. CurePSP does have a brain donation program, and I'll let Ella speak in if there's something at Mission MSA. But we do really encourage, if you're comfortable and if it's something you want to do, that's an opportunity for you. So that's my little plug for the CurePSP brain donation program.
Yeah, absolutely. And for those of you in the MSA community, we don't directly facilitate that, but we do work with an organization called the Brain Support Network. So if you have questions about that, please feel free to send us an email at that info@missionmsa.org, and we can definitely put you in touch with some resources.
Thanks, Ella. All right, in the last few minutes, this might be a big question. Casey and Alyssa, I think specifically, what would you tell yourself now, looking back at this, before your mothers even brought it up to you? What would you tell yourselves maybe at the beginning of the journey, now that you know?
Oh, good question.
I know it's a big question. I should have prepped you on this. I didn't think about it till now.
I think one to trust my mother, and to that would be like one part, and that there will be bureaucratic curveballs, and so to like just make sure that you have the time, the finances, the mental space, like to not downsell how much, especially doing this out of state, like how much of a big lift this is going to be while doing it in an emotionally intense time, like to not undersell like how big that is. But I guess, yeah, the main one too being to just trust that she knows what she's going through and what she wants, and that she would be happy in the end with her choice.
I think for me, it's just listening and communicating with our loved ones and listening to their wishes. And, like I said, my mom and I were a team the entire time. We made decisions together in her best interest. And so just listening to what she was communicating, saying what was happening to her, how to navigate it as her body was changing, as all the changes were happening, and knowing that we did the best we could together and we explored every option possible.
And so maybe one other practical thing is to use as many resources as possible, to not be shy about emailing people, about calling people, about reaching out to the different volunteers. Like there can be this, because you never know. Some will be dead end, some will be too busy, and some, like this phone call we made to End of Life Choices in Oregon, was like, life and death changing. And to never worry that you're going to be like bothering somebody with this like very big deal. You got it when you're advocating.
Yeah, great addition. Dr. Shavelson and Thalia, do you have any last words you want to make sure you said before we close it out for the day?
No, I think that you guys have done a fantastic job. And to say that, I hope that we can be helpful in the very, very difficult circumstances of neurodegenerative diseases. It's a lot of our practice, as I said before, it's out of proportion to the population representation. So the more you can teach us, we want feedback from you as well. We are an academy. That doesn't mean that we only teach. It also means that we learn. Right? And we learn from patients, we learn from clinicians at the bedside, we learn from lots of people. But feedback to us is more than welcome. And so there's a contact button on our website. Use it. If you want to say something to us or tell us something or have a question, we're quite available.
That's generous of you. And I trust that you mean that. And I really always appreciate your outlook on that. And getting to know you, I've learned that's very much the way you both work. And that's just really powerful, and appreciate that. Okay, well, everyone, I feel like we really could keep talking about this forever. We're at the end of the webinar, but I just want to thank our speakers and our panelists. This has been phenomenal, and we've had the chance to really dig into a topic that we haven't been able to before. And appreciate your candidness and your vulnerability and your honesty as we talk about these difficult things. And I appreciate all the attendees for joining today and facing kind of some hard truths, but also hopefully some pieces that give you hope or feelings of control as you go forward, whatever you choose in your life and whatever, wherever directions you go, just having information I hope is beneficial to you. Again, if you have any questions, feel free to reach out to either CurePSP or Mission MSA. We'd be happy to connect with you. There are a variety of methods on both websites for connection. If you want to review this webinar again, you'll get an email in a few days. And lastly, my colleague Brooke had put in a form to fill out, a feedback form. So feel free to fill it out, provide any feedback for CurePSP, Mission MSA, and anything on there for the Academy will be forwarded along. We'll make sure that they see those as well. So appreciate any and all feedback. Reach out. We would love to connect with you. You're not alone. We're here together with you, and you're here, and I'm happy to connect you all in support groups and other manners. So remember, you're not alone, and we're thrilled to have you here. Thanks, everyone.
Thanks, everybody.
Thank
Thank
you.
you.